Let's study juvenile angiofibroma. Earlier it was called as juvenile nasopharyngeal angiofibroma, but recently the nomenclature has changed to juvenile angiofibroma. As it is juvenile, so it occurs in the adolescents. Angiofibroma. Angio means blood vessels. Fibroma, it has fibrous tissue elements in the tumor. It is the most common benign tumor of the nasopharynx. It is predominantly the vascular tumor, as the name says angio, so it is a vascular tumor with varying amount of vascular and the fibrous tissue elements. In the tumor, there is varying amount of vascular and the fibrous tissue elements. The tumor has tendency to bleed. As it is vascular tumor, it can bleed profusely because there is no muscle or elastic coat on the blood vessels. On the blood vessels, there is no muscle or elastic coat, or in the vessel, there is no contractility. So it can bleed profusely. It occurs exclusively in the adolescents male. It occurs exclusively in the males. On etiology, exact etiology is unknown, but it is considered to be testosterone driven, as androgen receptor has found to be present in the vascular and the stromal elements of the tumor lesion. So, as it is testosterone driven, it occurs in males only. Site of origin. Earlier, sphenopalatine foramen was considered the site of origin, but the recent radiological studies have found that pterygoid vase is the site of the origin. Spreads. Medially, it spreads through the nasopharynx and the nasal cavity. Laterally, it spreads through the pterygopalatine fossa, pterygomaxillary fissure, and the infratemporal fossa, cheek. Superiorly, it involves the orbit through the inferior orbital fissure, cranial cavity through the foramen at the base of the skull to involve the sphenoid sinus and the cavernous sinus. Inferiorly, it involves the oropharynx. So it can spread medially, laterally, superiorly, and the inferiorly. Blood supply. Main feeding vessel of the juvenile angiofibroma is the internal maxillary artery. But ascending pharyngeal artery, median artery, vertebral artery, and if there is extensive lesions, then the feeders from the internal carotid artery is also seen. Main is the internal maxillary artery, main feeding vessels of the juvenile angiofibroma. On clinical features, we can see the nasal symptoms. There is recurrent epistaxis, which is the common presentation. This can be unprovoked and profuse. Nasal blockage, which is unilateral to start with. Later, it becomes bilateral as the tumor occlude grows, and to occlude the opposite side choana, this can lead to the hyponasality of the voice, which is called the rhinolalia clausa. There will be nasal discharge and facial pain due to the secondary rhinosinusitis. There may be ear symptoms. There may be hearing loss due to eustachian tube blockage by the tumor, leading to otitis media with effusion. There may be eye symptoms, proptosis and decreased vision if the orbit is involved. There is swelling of the cheek if the tumor has reached the infratemporal fossa. And there will be cranial nerves involvement if there is cavernous sinus involved. Cranial nerve 2, 3, 4, 5 and 6 are involved. Signs. As there is recurrent profuse epistaxis, anemia can be present due to recurrent blood loss. On anterior rhinoscopy and posterior rhinoscopy, the tumor is seen as the pinkish mass in the nasopharynx and in the choana. And if the lesion is large, This pinkish mass can also be seen in the posterior part of the nasal cavity. On nasal endoscopy, pinkish vascular mass is seen in the posterior part of the nasal cavity. Frog, frog face appearance is seen, in which there is proptosis and broadening of the nose. On otoscopy, we see the features of the otitis media with effusion, as the tumors are blocking the eustachian tube, causing the otitis media with effusion. There will be cranial nerve involvement 2, 3, 4, 5, 6. On investigation, diagnosis of the angiofibroma is almost always certain when there is male adolescent patient and there is recurrent spontaneous epistaxis, and on anterior or posterior rhinoscopy we see the pinkish vascular mass in the posterior part of the nasal cavity and the nasopharynx. Biopsy should never be performed because it is the vascular tumor, so it will cause heavy bleeding which will be difficult to control. As it is vascular tumor, so we can do the contrast enhanced CT scan, and in contrast enhanced CT scan we can see the enhancing mass along with the bone erosion, which is called the antral sign or the Holman-Miller sign, which is the classical sign of the juvenile angiofibroma, in which there is anterior bowing of posterior wall of the maxillary sinus. Here we can see the CT scan. Here we can see the anterior bowing of the maxillary sinus. It is called Holland-Miller sign. Anterior bowing of the posterior wall of the, this is the maxillary sinus. So tumor is spreading and cause the anterior bowing of the posterior wall of the maxillary sinus. We can do MRI to see the soft tissue extension in the orbit, infratemporal fossa and the intracranially. We can do digital subtraction angiography where we can see the vascular blast and identifying the feeding vessel, which will be important for the preoperative embolization. Preoperative embolization of the feeding vessel in order to reduce the intraoperative blood loss. For the treatment, surgery is the treatment of the choice. We can do endonasal endoscopic surgery to excise the lesion. Earlier, lateral rhinotomy, Weber Ferguson, and the mid-facial degloving was done. So basically, juvenile angiofibroma is the vascular tumor of the adolescent male with recurrent profuse epistaxis, which is so it is occurring in the adolescent male, which is testosterone driven. So it occurs exclusively in the males. It occurs in the pterygoid vase. Earlier it was found that it occurs in the sphenopalatine foramen. How it spreads. Its main feeding vessels is the internal maxillary artery. On clinical features, we can see this epistaxis, nasal blockage, nasal discharge, facial pain. Ear symptoms can also be seen, hearing loss. Eye symptoms, proptosis, decreased vision. Cranial nerves can get involved, swelling on the cheek. On signs, we can see the anemia and pinkish mass can be seen in the nasopharynx and the choana. Frog face appearance, proptosis and the broadening of the nose. Otoscopy, features of OME, cranial nerve involvement. On investigation, diagnosis is almost always certain when this history is given, when the patient is adolescent male and there is recurrent spontaneous epistaxis and pinkish vascular mass is seen in the posterior part of the nasal cavity and the nasopharynx. Biopsy should never be performed because it is a very vascular tumor which will cause heavy bleeding and it will be difficult to control. On CCT, classical sign is Holland-Miller sign. Treatment is mainly surgical. Earlier, there was lateral rhinotomy performed, Weber Ferguson, and the medial facial deglobing. This is all about the juvenile angiofibroma. Notes are given in the Notes are available in the Telegram and the links are given in the description. Thank you.